Okay, welcome back. Today we are going to take a look at this case, which is an MRI brain with contrast, as you can see, which is done for a 55 years old male patient presented with fever and also headache. So we can take a look first at the T1 weighted images. So as you can screen through the T1 weighted images, I think you already see some abnormality. In particular, there is an intraaxial lesion which is located at the left temporal loop. The adjacent white matter has some T1 hyperintense signal, okay, which is probably some edema, especially vasogenic edema, okay, and causing that there is a additional mass effect to the temporal loop and slightly more bulging uncle process of the temporal loop, but that is still preserved of the CSF, which is T1 hyperintense signal around the midbrain, which is called the ambient cistern. Okay, and then you take a look at this ventricular system. I think this is one of the quite useful sequence, I would say, whenever you're thinking along the line of ventriculitis, because you can see this is the definitely normal CSF T1 hyperintense signal. But can you appreciate that there is some T1 intermediate signal which is at a dependent portion, slightly more abundant on the left side, okay? So there are actually some dependent that breaks, okay, which is a classical features seen in ventriculitis. Okay, so actually the T1 weighted sequence may not be the best or commonly advocated sequence for pathology, but at least you need that to have a basic idea of the images, okay, before we know that where there is genuine enhancement in post-contrast sequence, right? Okay, but usually I will advocate you get more information from a T1 weighted sequence, because all the pathology actually do reveal themselves, okay, in T1 weighted sequence as well. And also it has its own advantage. For example, you can take a look, okay, at the bone marrow signal. Sometimes may be quite useful, especially if the disease entity involves bone as well, okay, although this is not the case in this particular disease. Another interesting thing that I want to point out is that you can see that there is a wall, okay, of this lesion, which is T1 hyperintense, okay. Actually, this is a less commonly discussed point, okay, because if this is a pyogenic abscess, then the presence of paramagnetic substance from the neutrophil, okay, as the wall will give rise to this kind of T1 hyperintense signal. This may not be the best clue for you to make the diagnosis, but surely it is very nice supportive evidence, I would say, okay? But even though you do not use other view, something that is not related to signal but the morphology of lesion can already tell you some clue. For example, you see that the thickness of this lesion's wall, okay, is quite regular, okay. For example, if you see there is a irregularly thickened wall in this lesion, for example, this side is much more nodular, much more thickened, then it must not be an abscess. This must be a neoplasm, okay. Otherwise, you cannot account for the very big difference in the wall thickness, okay, because it is not usual granulation tissue in abscess, okay. But in such a smooth regular wall, okay, both are possible, but at least, okay, neoplasm may not be the final answer. It can still be an abscess, okay. So let me go through another sequence and then we discuss the logic behind, okay. So you can see that, okay, so this lesion is having some rim enhancement, okay, rim enhancement, and apart from that, basically you can see that this time the dependent break is still seen, but apart from that you can still see some abnormal ependymal enhancement here, especially the left side, okay. The right side we do not see much enhancement, okay. So this is also a quite a late stage findings in ventriculitis as well, okay. Usually the most initial findings are just accumulation of the debris, okay? But if the inflammation is very significant, of course, the ependymal vessels will be engorged and there will be increased enhancement, and there is some periventricular edema, etc. Okay, those are relatively late stage findings, okay? How about T2? T2, of course, we can appreciate the T2 hyperintense ring, okay, corresponding to the paramagnetic substance from neutrophil that I've just mentioned, okay, and of course it is a good sequence for us to further delineate where this is an edema from which is vasogenic in nature. Of course, it's vasogenic because it is expanding and also occupying the white matter but sparing the overlying gray matter, okay. The main reason we already discussed in previous videos is that, okay, because there is some spaces, okay, at the interstitium, okay, between the white matter bundle tracks. However, the gray matter is relatively closely packed with cell bodies, so the fluid basically cannot sneak through between the cell bodies, okay, so they are relatively spared, okay. But even though it is very commonly mentioned that, okay, white matter edema are vasogenic edema, but mind you, okay, it only sneak through some loosely packed white matter tract. The closely packed corpus callosum can never be, okay, be sneaked through by the vasogenic edema. So whenever you see some so-called mass effect or edema signal across it, they are not vasogenic edema. You need to consider possibility of pathology that can target, okay, the corpus callosum, for example, tumor infiltration of GBM, okay, but it is not happening in this case. And this is the axial T2 weighted FLAIR sequence, okay. FLAIR sequence will further attenuate, okay, the CSF signal, okay. Something that is not CSF can only be partially attenuated. For example, you can see the debris quite clearly here, and you can see basically we have a T2 weighted slash FLAIR hyperintense signal around the ventricular system, okay. So you will ask the question, why we can't see that in the T2? Actually, they are present, okay, they are present, as you can retrospectively see the image again, okay, but they are not very easy to be picked up because of the much brighter CSF signal. That's why we need a FLAIR sequence, okay. And also, as you can tell, they are not purely fluid, but some debris. DWR is the single most game changer sequence in this case, because we can directly call for a restricted diffusion, okay, within the content of this lesion, which is suggesting it is the pus, okay, which is suggestive of pyogenic abscess. And of course, these debris are also having similar characteristics, which is also restricted as well, okay. To make sure that they're genuinely restricted, of course, we need to have corresponding ADC hyperintense signal like here, okay, as well as within the debris, okay. And you can see that they are not basically homogeneous within the ventricle. Some of them are actually more restricted, okay, depending how packed and also how purulent, okay, that's part of the debris is, okay. SWI, we do not have much information apart from the appreciation of there is really some paramagnetic substances, okay, supported by the blooming artifacts here, okay. So basically, when you see brain abscess, majority of the discussion will lies on, okay, whether it is a cystic metastasis or it is a brain abscess, okay. Both can look like a cystic lesion, ring enhancing, associated with pronounced amount of edema, etc., okay. However, if this is really an abscess, which is proved by the DWI and also ADC map, okay, you need to look for underlying causes. For example, for temporal loop, are they coming from the infection of the adjacent mastoiditis, okay? And the second question is there any rupture, okay, into the ventricular system? Because it is the single most poor prognostic factor regarding brain abscesses, okay. So this is another question that you need to bear in mind.